Podcast. This is the podcast dedicated to OCD, anxiety spectrum disorders, and getting your life back. I'm your host, Kevin Foss. I'm a licensed clinician specializing in OCD and anxiety disorders. Thank you all so much for joining me for this episode. This is going to be a fun one, a different one, a new one, something that we haven't talked about before, so that's exciting. So for those of you who are new, this is typically a question and answer based podcast. You can go over to fearcastpodcast.com and you can click on the submit a question link and you can send me your questions about anxiety and OCD and how to get over it, what treatment looks like, and how to help a family member, and anything related to that. That is what this podcast is all about. So you can go over to Fearcast Podcast. You can also go over to Instagram. I'm Fearcast Podcast over there. I have some instructions on my Instagram page on how to do it, but y'all know how to use Instagram. Send me a DM, click on the little microphone, record your voice, this is a separate conversation, I suppose. You can send me a text question at fearcastpodcast.com, but audio questions get shot, boom, to the top of the list and bypasses the wait list of questions that I have. And thank you so much, everybody, for sending me questions. As I've said before, the more questions this podcast has, the longer it's going to go. What I find most interesting, and it's been confirmed by a number of people I've talked to, having your voice is the most interesting. Y'all know what my voice sounds like. But if you send me an audio question, like over at Instagram, or you can record it onto your phone and email it to me at questions@fearcastpodcast.com, or you can send me, this is probably the safest and best way, upload it to like Google Drive and send me the link to that drive, or share it with me, share the link to fearcastpodcast.com, and I will put it up on a future episode in the next recording. So that is typically what this podcast is about, but this episode we're going to be talking about ARFID, which is Avoidant Restrictive Food Intake Disorder. It's something that we haven't really talked about, and doesn't come up as much in podcasts like this, but is certainly something that falls in line with the anxiety and OCD spectrum. So that's why we want to talk about it today. Before I get into that, if you like the podcast, if you enjoy the podcast, it would mean a great deal to me if you were to go over to iTunes or wherever else that you get your podcasts and write a review, give it 5 stars or whatever you feel is applicable. All it does is it helps other people find the podcast as you found the podcast, and hopefully it can help other people. I do no real advertising for this. Telling other people about it, tell a group, tell a therapist, gets the word out, gets more questions, keeps this podcast rolling. So that I think is all I have to say about that. Well, why don't I get into just my introduction about Dr. Megan Faye, who is the person I interviewed about this, and then we'll get into the interview. So, Dr. Megan Faye is a licensed psychologist specializing in the evidence-based treatment of obsessive-compulsive disorder, anxiety, and eating disorders at the Anxiety Specialists of Atlanta. Dr. Faye is the creator of the YouTube series Learning About Your ARFID and the forthcoming series Learning About Your Misophonia. So, without further ado, here is my conversation with Dr. Megan Faye. All right, Dr. Megan Faye, thank you so much for joining us today on the Fearcast to talk about ARFID.
Thank you for having me. I'm really excited to be here.
This is very exciting. So we're going to see how technology goes. For those of you who can't hear what I just cut out of the podcast, we've had some technical issues, so we're going to see how it goes on both of our ends. My computer is doing weird stuff too. So
okay.
It's going to be an exciting game. But Dr. Faye joined me today to talk about her expertise, her interest in ARFID. And it's something that isn't normally talked about. There's not a ton of information out there, or at least a ton of good information out there on ARFID, what it is not. And I'm delighted to have you on to educate all of us and to perhaps dispel some misconceptions about what it is and to talk about how it's treated.
Absolutely. Yeah. ARFID is very much in its infancy of treatment and research. It's only been in the front of the Diagnostic and Statistical Manual, which is our manual for diagnosing mental health disorders in the United States, it's only been there since the most recent iteration, the DSM-5. Prior to 2013, it was considered more of an infancy feeding disorder. So it's still just getting some recognition and some understanding of how it presents and how you treat it. So hopefully I can provide a little bit of a background and a baseline for how to get started, what it might look like, but also that that's subject to change as more research is done, which is hopefully on the horizon.
Right. Well, why don't we start off with just what is it?
So ARFID, which stands for Avoidant Restrictive Food Intake Disorder, is technically an eating disorder. And I know we're here on an obsessive compulsive disorder and anxiety disorder focused podcast, but a lot of really great treatment for ARFID is in that domain. And we'll talk about a little bit why that is. But it's an eating disorder because the primary symptoms are on issues with eating and food. But it differs from other eating disorders in that it is not about trying to control weight or body image, but it is very much about food itself. So people with ARFID typically fall into one of three categories where they have a lot of issues eating that can lead to nutritional deficiencies. It can lead to difficulties making expected weight gains or having health issues. But it can also have significant psychosocial impairment, which means there can be a lot of difficulties eating across settings, being able to do things like go on dates or go to sleepovers as kids. But the three categories that people tend to fall into are a little bit different. One is a lack of interest in eating and food altogether. And sometimes people in that category have trouble getting themselves to eat. They have low appetite. They're fatigued by it. They don't find food to taste very good. Then there's a second category, which tends to represent most of the people that I see. And it's more of a sensory aversion to food. And that can start to look a little bit similar to OCD. So there's a little bit of sensory processing elements where people might be disgusted by food. It's not necessarily an anxiety around food, but there's an actual strong disgust reaction to certain foods, certain textures. Sometimes it can be based on temperature or color or whether there are edges to the food, whether they have the specific brand. So that's when we're starting to get into particularities that look a little more subjective rather than just that feeling. But you'll see people resisting the urge to have their foods touch each other or eating chicken nuggets from one fast food place when they could get them from their favorite fast food place. So it starts to get very particular. So that's the second category. And then the third category is more about fear of the aversive consequences of eating. And that can be a fear of vomiting if you eat or choking if you eat, which starts to look a little bit more like a specific phobia reaction. But it's usually based off of past experiences where maybe there was an allergy or there's some sort of underlying medical condition. And that fear can be related to having an invasive medical procedure because of eating a food that they've had a reaction to as well. So there's an element of a flavor of trauma to that sometimes too. So those are three very different categories, but all falling under that same heading. But essentially, it all comes down to, are you having trouble eating a variety of foods? And is it really getting in the way of your ability to live your life fully and live your life healthfully?
Right. Yeah, those categories are they are very broad, and I'm certain that someone listening to this could find themselves in a couple of different categories. To that end, when you're working with someone with ARFID, do you find that they fall within one category, or do they kind of span a couple or even all three?
Interestingly, most of my clients tend to fall into one of those categories, and they can have some other co-occurring mental health concerns, but many times they don't. That is just that one thing, and it can be very much specific. There can be some long-standing issues, so I guess I should back up a little bit. ARFID tends to be something that is lifelong. Most people that experience ARFID report experiencing it since birth, since infancy, and it starts to become more noticeable often for many people around the time that they have to transition onto solid foods, and then they start rejecting certain solid foods. And then there can be this kind of reinforcing cycle where if you don't try very many things, your palate might develop in a certain way, or you might develop a more extreme aversion. And so it can be very cyclical where because you don't eat very many things, it's harder to eat more things. And if you don't like stuff, you might not be eating throughout the day. So you might not actually have hunger cues. You might not want food. So there are ways that it can bleed into the different categories, but very often people have a real primary issue with one of those three categories, in my experience. That's not necessarily a research-based answer so much as an anecdotal answer.
Yeah. How does this tend to develop? So how do you first start to see these symptoms showing up? And you kind of said it can show up as early as childhood or even infancy. But I guess where do you first start to see it showing up, and how does it typically develop?
Yeah, that's a great question. So as a caveat, I tend to treat people who are actually teens and adults with a mixture of kids in there, which is a little bit different. Many ARFID specialists are more in the kid domain and work with parents, or you'll find them in feeding clinics for very young infants that are, for instance, not switching to solid foods. But typically you start to see it showing up around that time period where infants have to transition onto solid foods, and you start to see the rejection there, or the difficulties there, or they start showing, if you're in that domain of like fear of a medical consequence, you might start to see some allergies that then lead to restricting or refusing certain foods. But then there's a degree of normalcy of picky eating. Many people refer to ARFID as extreme picky eating. It's a little bit more than that, obviously. It's a lot more restrictive. But there's a degree of normative development where most kids are pretty picky. Most kids really would prefer to eat chicken nuggets rather than broccoli. And that's not unusual.
I think that's to be fair for everybody.
Yeah. And so it starts to be, adults as well. But there's a difference between and then the point where it starts to really impair physical development and emotional functioning. So when you're starting to get into, for instance, less than 10 foods is often the magic number touted by researchers. If you don't eat more than 10 different foods and you have a real extreme reaction or disgust or fear or distress around even thinking about eating other foods, you're probably falling more into the ARFID category. And so around ages 2 to 6 or so, that middle childhood period, it's considered relatively normative to reject certain foods. But if it's getting more extreme and you're not seeing like growth or developmental milestones being met, and then once you get past that age 6 window and it's still really tricky, you might be seeing more of that ARFID diagnosis.
Okay. I appreciate that greater detail of it. I didn't intend this, but I'm in the middle of this all of a sudden going like, because I have a couple of kids and they're going to be 2 and going to be 5, and I'm in my head going, gosh, they don't like to try to eat other different foods. So I'm thinking as with my parent hat on, there is going to be that typical expected food kind of rejection, that not wanting to eat certain foods, only wanting to eat chicken nuggets and French fries, and that sounds delightful. But seeing that difference of when it starts to escalate or it starts to become more restrictive, or I love the acknowledgement that if there's missing some developmental milestones, perhaps it is related to their dietary restrictions.
Yes. And that missing developmental milestones or not getting adequate nutrition tends to be the main thing that identifies kids early on of this is something that needs some intervention. And even if someone is not necessarily fully meeting criteria for ARFID in a clinical sense, they can still benefit from a lot of the different interventions that tend to be helpful for targeting ARFID. And a lot of those tools are actually tools that many parents use anyway to get their kids to try new things. Like there's a tool called chaining, where you chain something that is preferred with something that is not preferred. And essentially you're trying to practice having a little bit of the thing you don't like with the thing you do like, and slowly changing the amounts so that over time you're eating more of the thing you don't like and less of the thing you do like. And that's a classic way to introduce broccoli to kids, by putting cheese on it. That is just what most parents do. And over time, you try to get rid of the cheese and just eat the broccoli. So a lot of those strategies are things people use with children anyway. So there is a degree of normalcy. It's just how impairing is it?
Right, right. I guess could you tell us a little bit about the clients that you tend to see, and what are some of the common themes or common things that you're seeing, and helping them work through?
Absolutely. I think something that starts to come up that really differentiates that normal range of being picky or having preferences and getting into the ARFID spectrum is there is often a really intense disgust reaction to food. So foods that are outside of the preference or outside of the rules that someone with ARFID might have developed for themselves tend to really elicit a very strong reaction. So I have clients, adult clients, where we'll practice just tolerating disgust. And a lot of the exposure practice that we do is intended to practice tolerating feelings of disgust, not necessarily learning to love lots of things so that people can be able to eat. Essentially, that is the underlying theme. Someone with ARFID often struggles to be able to eat. So I'll have clients where we'll practice biting into grapes or biting into beans because that bursting sensation is really disgusting. And you'll see it on their face where they'll bite into it and everything in them wants to spit the food out. It is absolutely, truly disgusting.
Right.
And so that's more the range of where I'm seeing clients who are absolutely, truly disgusted, or they'll engage in a lot of checking behaviors and ritualistic behaviors around food to make sure it's right. So a lot of clients that I treat, especially adults who have been living with ARFID most of their lives, if not all of their lives, will have developed a lot of unconscious rituals where they'll pick up their food and they'll look at it and they'll inspect it and they'll see how soggy is it? How crisp is it? Are the edges the way I like the edges before they put it in their mouth? And so we'll do a lot of work around disrupting those kinds of just right rituals and practice tolerating the possibility that that food might be disgusting or it might not be right. And we're going to lean into that and learn how to eat it even when it's not right, so that you can do things like go on a date or go to summer camp. So the clients that I see mostly fall into that category of being very preferential and having a strong disgust reaction. But I also work with clients that find food just not interesting at all. And so that will be more in the domain of working to build hunger cues, because a lot of them don't get hungry and they're underweight because they're not eating enough. So that'll be more in the domain of how can we practice just feeling full and practice eating when you're not hungry and eating on a schedule so your body can start to anticipate food. But then we also have that category that's more in that phobia. So I also treat clients that have had really negative experiences, usually because of an allergy or because of a medical condition where this is more children that I work with. Yeah. They'll have some sort of acid reflux or something like that gets triggered by certain foods. So they've gotten afraid of eating foods. So that'll be more in the domain of let's practice eating and testing out what happens and learn to tolerate or maybe retrain that gag reflex or sit with the uncertainty and deal with the consequences if something negative does happen, but maybe it won't always happen. So we're taking some risks. So those are some examples of the kinds of things I'm doing with clients.
Right. I've worked with a couple of clients with ARFID in the past, and that disgust element of it is, at least in the clients that I saw, it's so prevalent. And it's like everything in them just says that this is awful and terrible and the worst possible thing that could ever happen. And it defies logic. I can imagine a lot of people out there saying to try to explain, hey, why won't you eat beans? They're just beans. Who cares? They're beans. It is beyond explaining. It's not like I don't like the flavor. Some people don't like broccoli because they have the gene that, makes it so that it tastes bad. I guess Brussels sprouts are the same, right? But it's different than that. It is an inexplicable just aversion to it.
And I'm glad you brought that up, because there is some research that suggests that people with ARFID may actually have a different structure and there's some differences in hormone levels in terms of the way they're experiencing satiation. Some people with ARFID, not all, but there's also some suggestion that some people with ARFID, especially that disgust category, might be super tasters, where they might have a higher concentration of, this is really outside of my window of expertise, but they might have a higher concentration of essentially I want to say taste buds. I don't know if that is the real way it's described, but they taste flavors more intensely.
Okay.
And they may taste certain foods as more disgusting because there is something going on in the way they're built neurologically or in terms of sensory processing. So I also want, when I work with clients, I want them to be realistic about, we're not necessarily going to love lots of foods because this might just be kind of how you're built.
Yeah.
But different things that you've been doing might be reinforcing some of the preferences, some of the aversion. And by practicing, often many of the clients that I work with learn to be able to eat a lot more foods more freely, and they're less disgusted by them.
That is fantastic. I mean, I think that's a really important element here to recognize for someone maybe struggling with this and wanting to then get, be able to go and have the freedom that, the other person has to be able to go out and eat certain things, et cetera. The goals of therapy, the goals of treatment might be different from what they are currently expecting, right?
Yes.
We have clients come in for OCD or phobias, and they'll say, I want to be rid of this anxiety. Well, we're not here to get rid of a feeling, and disgust is one of those feelings that we have. Inside Out taught us this. So it's that we have those feelings. It's not about that we get it, but it's, can you do it even though? Can you do it despite the fact that you have this reaction? And I guess could you speak a little bit to the goals of treatment for someone who's listening to this, going, man, I'm sick of this pattern that I've fallen into or I've developed over the course of my years. What goals are realistic for someone going through this process?
Yeah, usually we try to look at three main broader goals. One is to learn how to tolerate disgust. Usually, I'm saying disgust because most clients have difficulties with disgust. Sometimes it's disinterest. Sometimes it is fear and avoidance. There's a lot of avoidance in all of this. But really, we're learning to handle that feeling that makes them want to avoid the food so that we can practice eating even when you have that feeling. And that helps reach broader goals, which I try to highlight as maybe more important as loving lots of foods and more, we want to get adequate nutrition so that you can be physically healthy. And we want to be able to go places and do things. Those are two huge limitations for many people. And especially when we get into adults who are able to, they've lived that life for a long time and they're able to say, okay, yeah, those are my goals. Kids, it's a little trickier because they're a little more immediate gratification. They're like, why on earth would I do this thing if I hate it? So that gets more into the parent focused side of things where parents have to learn different tools for, okay, what am I reinforcing versus what do I want to stop reinforcing when it comes to food avoidance? So that's a whole other ball of wax. But when it comes to people that have higher order thought processes and delayed gratification, we try to focus on how will this add to your life if you can get through this moment and be able to live for more moments, bigger moments that mean more. So that's where we get into that idea of a lot of people I work with are pretty isolated. They're afraid to go to parties. They're afraid to go on social experiences because they're not sure if they'll be able to eat or if it will be embarrassing or if they'll be hungry and upset and, socially feel strange trying to order chicken fingers when everybody else is ordering steak at a nice restaurant. And so people's lives get very limited in that way. So we try to work towards that. There's another piece on the nutritional side of things, which is there tends to be this idea of someone with ARFID being underweight. And often that is how it's described with children, like failure to meet goals and growth curves. But many of the clients that I work with are actually also overweight. There's kind of two ends of the spectrum because you're thinking about somebody that's got a limited diet that's often junk food, because very often people with ARFID prefer things that are higher in fat, higher in sugar, because that's tastier and that's more comforting. Sometimes I've worked with people that have the opposite, where they'll only eat vegetables and they won't eat things like chips and fries and chicken nuggets. But if you're having a diet like that's high in carbs and high in fat, often you're seeing different nutritional issues where you're having high cholesterol and other pre-diabetic, those kinds of health issues that have to do with that kind of diet. So it's kind of two ends of the health spectrum there.
is there a difference in the treatment or the way that those are approached, or is it all just kind of in a values-based decision to change diet and to incorporate things that you just don't really like, but you're doing them anyways because it's important?
Yeah, the goals tend to be the same, and I am very client-centered. I want to meet the goals of the client. So if the client doesn't feel like weight is a concern for them, then we're not talking about, weight and body image. But sometimes just to kind of back up a little bit, my background before working in anxiety disorders and obsessive compulsive disorders, which is primarily the space that I operate in now, I started off in intensive outpatient eating disorder treatment. So I also work with people on the more widely known eating disorders like bulimia and anorexia, especially when you get into that space of overlapping with OCD and eating disorder behavior, which comes up a lot in the anorexia space. So people will get very stuck on certain rituals and calorie counting and weighing themselves that can get very into the perfectionistic obsessive compulsive space. But so when I do work with clients, I want to honor if there are other eating disorder concerns beyond just the ARFID, because sometimes people can have more than one thing. So I have people with ARFID who also struggle with binge eating disorder and body image concerns and body dysmorphia. And some of that can be related to their history of issues with diet and some of the messages they've received around what they should be doing, how they should be approaching and experiencing the world. And in that case, I want to make sure I'm addressing all of their primary goals beyond just, okay, what does your health look like? And thinking about how those messages around focusing on something like health as related to being overweight could negatively impact their sense of self-worth and contingencies of self-worth. So it's a little bit of both and in that respect.
Right. I can imagine it gets to be a little tricky to start to separate those and which behaviors are related to which disorder, and then trying to develop a treatment plan to address both of those simultaneously.
Yeah.
Could you is there an overlap between ARFID and orthorexia?
That is an interesting question. Typically, orthorexia tends to fall more in that anorexia nervosa space. So one of the main distinguishing features between ARFID and some of the other more widely known eating disorders like anorexia and bulimia is anorexia and bulimia tend to be one of the main criteria is an undue focus on weight or body shape. And orthorexia, which is not necessarily a formal diagnosis, but it is kind of an other specified eating disorder diagnosis, it tends to fall into that category of typically some of it is motivated or driven by a desire to control weight and body shape, but in the space of under the guise of being healthy. And there's an undue concern on exercise and being healthy and potentially, more in, it can get a little bit into the muscle dysmorphia and body dysmorphia space, but there does tend to be a focus on image. Whereas with ARFID, there tends to be very little concern about body image and weight. It's more about like the functional impairment that not being able to eat plays a role in their life. But I have not met many clients that really seem to care a whole lot about their exercise and being hyper-focused on that, which is more in that orthorexia space. I hope that was clarifying. It got a little muddy in there.
It totally works. I mean, because they're, I think that, for someone who may be finding this podcast who, they may have a loved one who may be experiencing them, or they have it themselves and they've heard all these different terms. I mean, in the world of, anxiety land, things can get in therapy land. There are way too many acronyms, way too many big words and things that are just wildly confusing. But I think it's helpful to pull those apart so it doesn't feel like someone is just acquiring all these big stinking names that point to why they're broken. But it's, that they can be, they can find a home in a direction rather than it's just feeling like, well, they have all the things. But I appreciate that differentiation with orthorexia, because there can, somewhat be that overlap. Anyways, I don't want to keep belaboring that point. Yeah, you did.
Well,
you done good.
Thank you. I think something just like a really very baseline summary of ARFID compared to the other eating disorders is that ARFID, people are not eating because they feel like they can't, not because they don't want to eat or they're trying to control something.
That's perfect. And yeah, there's that limitation. I anticipate there's a lot of, or is there, you can tell me, is there overlap then between ARFID and depression? And or what are some other comorbids that you might see? Obviously, we've talked a little bit about the traditional eating disorders, but in what other comorbids might you see?
And I don't know what the statistics would be, which is a really interesting question. But in terms of my personal experience with clients, there's a lot of sadness and distress and isolation associated with the ways ARFID interferes with their ability to live a full life. So in terms of being able to go out with friends and do things and not have to worry about what you'll eat or how you'll eat or what it's like, it limits freedom. And so one of the ways that I like to approach treatment with my clients is by eating stuff that feels disgusting and working through that feeling. Mm-hmm. That means you can eat anything, anywhere, and that's freedom. That gives you your life back. So while ARFID itself is not necessarily a direct link to depression, it can certainly lead to certain limitations that can interfere with the ability to feel good and satisfied with life. There is, on a biological level, another piece of that, which is there's a side effect of malnourishment, a side effect of being very low weight. Yeah. And this happens with anorexia. This happens with people that just don't have access to food, for instance, victims of war and famine, but also in the ARFID space, where if you are very low weight, you tend to be anhedonic, which means there's limited reactivity, low experience of emotions, limited pleasure. So it's kind of like this flatness that can feel kind of depressing, but you also don't really care that you're depressed, but you do. So it can be very hard to do something about it because you just don't have the energy to have those emotions when you're that low weight. And it's actually protective. It's your body's way of keeping you alive, because if you're freaking out, you're not going to be able to get through whatever crisis you're in that's leading you to not have enough food. And
you're expending a lot of calories to freak out.
Yeah.
Right.
Absolutely. That is the clinical term.
Well, I guess, so ultimately, I think the most important thing with all of this is going to be the treatment of this and how somebody can work their way through this. You've kind of alluded to the differences between how this might show up or treatment might show up for kids versus adults. But I guess tell us. I mean, your main focus is teens and adults, teens and up. Tell me a little bit about what treatment would look like for them, and what someone out there who may be listening to this who wants to get started but may have trouble accessing treatment for whatever reason. What is the course of treatment going to look like for someone struggling with ARFID?
Yeah, I tend to take a cognitive behavioral approach and use of evidence-based practices that tend to. There's some research that shows that it is very effective for ARFID. There's very preliminary research, but also borrowing from principles of ACT, where we're learning to accept certain elements of the situation and be able to work through it without getting too stuck on stuff. But essentially what we try to do is look at how we're thinking about situations, what are the beliefs about that situation, and how can we practice testing it out and learning to handle that potential worst case scenario, but also maybe collect new data about how it will go. Maybe it will be disgusting, but maybe we can handle disgust. Disgust is not necessarily dangerous. It is a primary emotion, and it is intended to tell us important information about our environment, just like anxiety. Anxiety is intended to help keep us alive. But when we have anxiety disorders, sometimes it's getting a little too far to the right, and we got to get it back to the middle. Same with disgust. Disgust is intended to tell us, hey, that food is poison. You definitely shouldn't eat that because you're going to die. And we want to practice engaging with the food to test out that belief. So far my patients haven't died from trying the foods I've given them. Sometimes if somebody does have this is my caveat. Not yet. They could. We're sitting with the uncertainty of that. If somebody has a history of allergies and they have a restricted diet, then there is that caveat of you should probably try food for the first time under the supervision of your doctor to see if you actually have an allergic reaction. Because if you haven't tried a lot of things, you truly might be allergic to certain things. So if there's like a family history or a possible personal history, that's my one caveat to the, hey, if you eat this, you probably won't die. Like you could. We're going to lean into that. Yeah. But for the most part, what we're doing is practicing doing experiments, doing exposures, and practicing tolerating that sensation. And I like to do things in a progressive, stepwise fashion where people can learn, okay, I can approach this thing a little bit. Let's take one further step and then another step from there, rather than just saying, okay, eat this hamburger, let's do it. So usually I will start off with something that engages the five senses. That seems to be a very simple, straightforward approach that people can use. And I do this with kids. I do this with adults, where we'll practice just being around the food and identifying, okay, what are your rituals? What are your core fears? What is the thing you struggle with? How can we approach that in a certain way? So if it's about certain foods touching each other, like let's have that fear food on the plate and we're just going to have it there. We're going to practice having that normalized, that it's a part of dinner, it's a part of your meals. Let's bring it in. It's just around. And then from there, we try to take a step further. We're going to touch it. We're going to play with it. Okay, now we're going to smell it. And we're going to take a bite and spit it out. And then we're going to take a bite and hold it in your mouth for 5 seconds. And then we're going to spit it out. And then we're going to take a bite and chew it and spit it out until we're working our way up to actually swallowing the food. And most people, when they come into my office, especially kids like to come in, they don't have any anxiety about bossing me around. And they come in and they're like, I'm not eating that. Just so you know, like, I'm not eating that. And I'm like, cool, you're in charge. You don't have to eat it. But what if we just hold it? Could you hold it? And they're like, no, okay. They're usually more willing to do that. So we're just trying to do one step at a time and introduce the possibility of like, okay, maybe you can handle this if we do it incrementally. But I also really try to focus on giving my clients power and a sense of control where we are doing something that is scary or upsetting or disgusting, and we're going to do it, but you have say in how we're going to do it. And you can always say no. I don't want my clients to be forced to do anything because that's not necessarily helpful. No. And especially with kids, I usually really try to respect when they say no because they're not used to that. And then they trust me that I will listen to them if they say something is too much. So that's important. But I try to encourage them to take steps outside of their comfort zone. And when it comes to kids, reward can be really, really valuable in getting them to step outside of their comfort zone. But really doing the exposure practice of how can we go towards this thing you want to avoid. Right.
Oh, man, I love all of that. People couldn't see me fist pumping when she was describing all of this. I mean, I assume in this process that you're describing that that process of going from I'm not eating that dumb food to sure I'll have it in my mouth and I'll chew and swallow it. This is not one session. This is over the course of numerous sessions. Unless you're go ahead.
It depends. I'm looking to my right because I have a little game here. Okay. And I'll do games with people, teens and adults, it depends on how much they want to play a game because I don't want to make them feel too young, but I love games even with adults. But with kids, I have a game where we will work our way up that step ladder. Usually we'll try to get to it by the end of the session. So the one that I have here was for a kid, and I'm just going to pull it up so I can look at it. But we have a beautiful stepwise description of step 1 is hold the food, play with it. Step 2 is smell the food. Step 3 is lick the food. Step 4 is take a bite and spit it out. 5 is take a bite, hold it in your mouth for 5 seconds and spit it out. 6 is take a bite, chew it for 10 seconds and spit it out. And then 7 is take a bite and swallow it. But part of this is each of those steps is worth more points. Ooh. And then they have a specific prize that they want to get by the end of the session. And sometimes it's something that I have for them. Sometimes it's something their parents have planned for them. And so if they can get that point value, like they'll get something no matter how many points they get. So it's not just like you either succeed or you fail. But if there's something they really want, then they'll get to the end of that step ladder and they'll see that they can get there. And then they get that thing that they want.
I love that. How do you work that with so all right, to step back. So that process that I would assume would take multiple sessions, this could very much be done in one session. But, is there, because I imagine there are going to be some parents who are going to say, this kid's got to eat some broccoli. Should they, what expectations do you have on that, or how do you temper expectations for, I'm thinking especially parents or loved ones who are like, we're sick and tired of their limitations.
Absolutely. It depends on the kid and it depends on how reward motivated they are when we're talking about kids. But a big piece of this, both with kids and adults, same as any treatment for an OCD or anxiety disorder, is that you have to practice. The people that do not practice tend to take a very long time to make progress. So a lot of my adults take much longer than the kids because the adults don't want to practice between sessions. They'll practice in session. I consider myself like a professional peer pressurer, but it's very hard for them to go towards practices between sessions because they don't want to, and it's disgusting. So we try to find ways of motivating them or setting up a schedule. But often that scheduling piece is a big part of it. So often, regardless of whether there's disgust or whether there's difficulties with just liking food in general, a big piece is starting off with building hunger cues and restricting access to the easy foods. So you want to have the foods that are harder to eat around and maybe keep less of the stuff, or restrict access if you're a parent. Like, don't just have chips laying around for your kids to eat instead of eating their dinner, so that you're building up hunger. And not everyone will eat when they get hungry when they have ARFID. So I do want to have that caveat of, I'm seeing people who are medically stable on an outpatient basis.
Right.
There is a subset of people with ARFID that no matter how hungry they get, they will not eat. And they tend to be more on the medical side and need things like a feeding tube and stuff like that.
Right.
So that is something that can happen with ARFID. But in terms of making progress, doing a practice every single day, eating on a schedule so that your body can start to anticipate when it's going to eat so it can get hungry for it, restricting access to the preferred foods between meals so that you're not just snacking on stuff and then not getting hungry enough to try the disgusting food, eating the disgusting food with preferred foods. So you're pairing them together, you're chaining them together. So you get that aversive with the desired and they're together. But also doing the challenges at meal times can be very helpful, because then you're normalizing that we eat foods we don't want to eat at meals. It's not just this special exposure practice piece, which is an exposure, for those who don't know, is a planned practice where you have a set beginning and end, you know what you're practicing. But we want to normalize bringing in foods that are avoided into meal spaces where they are typically eating. So it doesn't become a special thing. It's like, okay, this is what I do. I try hard stuff during my meals.
Right.
And if they're a kid, really, really reward them for their practice, setting up a point system, and they can earn points. And if they don't do the challenge, then they might not get the prize, but you're not punishing them for it. So that's also important too.
Right. What's the role of, like, forceful battles between kids and parents in the development of this? Like, parents forcing a kid to try to eat broccoli, or, whatever weird food it is for them. I know we're picking on broccoli a lot today, but whatever that thing is that you just don't like, what role does that play in the development of ARFID? Does that make sense?
That is, yeah. And that is super tricky because we are towing a line. One way of looking at it is we want to reinforce the behavior we want to see, and we want to stop reinforcing the behavior we don't want to see. So something that can happen with kids is when they avoid a certain food and then you introduce it, they'll get really upset. They'll have a temper tantrum. And that's really hard as a parent to sit through and just deal with and take every single time. Right. But sometimes, depending on how you're responding to it, you might be giving attention when a kid is refusing food. And so we want to notice, are we providing them with some kind of unanticipated reward for having a negative behavior? It's kind of parallel to if your kid has a full-blown tantrum at the grocery store because you won't let them buy, a chocolate bar or whatever, and you give them that chocolate bar, what you are sending that message is, oh, this is a good way to get a chocolate bar in the future. And so we want to be careful that we're not reinforcing tantruming and negative behavior, and sometimes just even being selective about attention can be a part of that. But it's really tricky. There is something called the Picky Eaters protocol, which is by some researchers in Philadelphia, Catherine Dalsgaard and Jessica Bodie. And they have a really great set of different tools and rules for parents that they've done some research around. Some of it is contingency management. So that can be and I don't remember if it's coming from their protocol, or there's also a CBT for ARFID workbook that's really great by Jennifer Thomas and Cameron Eddy. And I'm not affiliated with any of these people, but these are some of the only resources that are out there for ARFID, and are really great and very parent focused. There's also Faye for ARFID stuff too. Those are like the three big people. But contingency management, one of the recommendations is picking something that a kid wants, kind of like a reward, and then reducing access to that thing throughout the day so that they only get it if they do the exposure practice. And it's not a punishment, but it is an incentive. So for instance, screen time is usually one that's picked. And so if you remove access to screen time, and their access to that screen time is contingent upon completing an exposure practice, they can choose, like, I don't want to have screen time. That's how much I don't want to eat that food. But
choices.
If they do, that can be a very big incentive for actually practicing so they can earn that reward.
Right. And then
I think I lost the question there. I went down my own tangential path.
That's totally fine. It was more of, that you're kind of getting at, you're answering the question plus. So well done. Check plus. But it's the idea of like, how much of like when parents are trying to like force their kid to try something new, that, when they engage with that battle, the kid is probably going to be digging their heels in even more, and then limiting just based on control, and just this is the one control or one place in their life where they feel like they can absolutely, control what does or does not go in their mouth. And, to whatever degree that contributes to it. So you certainly answered that question. I don't know if you have a hard out at the top of the hour, if you have clients coming up. So
I'm good.
Oh,
yeah.
Okay, me too. But also, would you be able to send me those some of those resources you talked about? Because I can tag those onto the episode page at Fearcast Podcast, so folks can go over there and kind of see what those are. Is there anything else that you feel that you'd want to add to kind of give folks a clearer idea about what ARFID is and what treatment looks like, or specific things that folks can be thinking about if they are struggling with this, if a loved one is, or even if a clinician out there is working with someone with ARFID? What sort of things should they be wrapping their head around? It's a lot in that question.
No, I think those are really, really important questions, because there's two different pieces that really tend to fall to the wayside when it comes to treatment. One is trying to even find a treatment provider. And a lot of people with ARFID struggle for years to figure out what they have and who can treat it. And often very young children fall into feeding and eating clinics at children's hospitals. But then after that, it kind of dries up a little bit. And so most people start out looking at eating disorder clinics and eating disorder specific treatment because it's an eating disorder. And sometimes that can be incredibly helpful, but sometimes it's not quite hitting the mark because those treatments often focus on some of the different pieces that contribute to an eating disorder, like trauma experiences or undue focus on body image and weight and that emotional side of things that people with ARFID are not necessarily experiencing. So that it can be hard for that to be as helpful as exactly what they need. And they don't realize that obsessive compulsive disorder and anxiety disorder focus, so treatment providers that do CBT and ERP and ACT can actually be extremely helpful for treating ARFID. And a lot of those providers do that ARFID intervention work, but it's not as well known. And people that do that work, those clinicians, often feel scared of doing ARFID treatment. But ARFID treatment is very responsive to a lot of the same treatment interventions that are used for anxiety disorders and obsessive compulsive disorders. So I strongly encourage both patients that are looking for treatment providers to look at that OCD anxiety disorder space for a treatment provider, but for those treatment providers to consider, hey, you already have those tools. You can apply this with ARFID. It just seems scarier or different because the word eating disorder is in there.
Right.
But it's very similar. The caveat to that is it can be really, really valuable when you're in the eating disorder space to have a treatment team that includes a medical provider, so a primary care physician that can really track, okay, are there any health consequences or medical consequences of this? Because there's often nutritional deficiencies that go alongside it. So that's important to get that monitored. But then also working with a dietitian, because a dietitian can help design a meal plan and say, these are the things you need in order to be healthy. You need to be eating this, you need to be eating this, and this is how many times a day I recommend doing that. And as a mental health provider, that's kind of outside of our expertise. We can read books and make some deductions, but getting that specialist on board can be really helpful. And then you can say, see, they said we should be doing this. So that's what we're going to be practicing.
And I can see that also certainly providing that structure and the target for what the eating schedule is going to look like based on what their medical need is, rather than just kind of shooting in the dark with what you want to start eating. Absolutely. Yes. So all of this should be tailored to the individual. We're talking really broadly about different themes and different things we can do, but really the individual need is going to be paramount, and it's going to differ based off of, what everybody's going through. So it's good to have your own treatment team that can tailor your plan to what you need. Awesome. Yeah, I think that can certainly be encouraging. To go back to your previous point about saying, if you're looking for somebody, check out, instead of just purely eating disorder folks, even checking out the IOCDF and finding a therapist, or finding a IOCDF registered therapist can be a good place to start. And, I'll plug them. Go over there, put in your zip code, and it'll pop up with a bunch of therapists in your area that can work with you on this stuff. So that can certainly open things up. Absolutely. And interestingly, like I mentioned at the beginning, I started off in intensive outpatient eating disorder treatment as one of my first clinical experiences. So I started off working with eating disorders. That was about 10 years ago. So that was right before ARFID really made it into the DSM. But I don't remember even hearing ARFID being discussed. And that has certainly changed. I know a lot of treatment programs, including the one that I worked at now, does treat ARFID and they include it. But I didn't treat ARFID until I started working at a clinic that specialized in OCD and anxiety disorders, because that was the space where they were seeing those clients and doing those interventions, and it's very effective and helpful. Right. Well, all of this has been super interesting and really informative. Is there anything else that you'd want to add to if there? I often end. Is there one thing that you'd want to tell someone who's either struggling with this or encouraging someone who is struggling with this? What's the one thing that you'd want to tell them? I would say that there is hope and things can change. And it doesn't mean that you'll magically love lots of different things, but you can absolutely learn to tolerate disgust and work through fear and urges to avoid and be able to live a full life. And it takes some practice and it takes some hard work, but it is absolutely doable. Love it. Love that sense of encouragement. And it can be hard work, but it's doable if you work it. So absolutely awesome. Well, I also ask everybody, if someone's listening to this episode and they have a specific question about ARFID or ARFID treatment, and they would like you to answer that, or they would like you to discuss this, would you be willing to jump back on in the future and answer that question?
Yes, definitely. I would love to. And I also want to plug very briefly some free videos that I've made on YouTube to try to provide some education about ARFID, because a lot of my clients haven't been able to find that information. So I'm trying to put together some different, brief 8-minute videos on these different topics too. So that's out there too. It's called Learning About Your ARFID.
Awesome. And I'll post a link to that as well. And I was going to say those videos are great. I did watch some of those and they are very good. So they're concise, they're clear, they're a wealth of information. So thank you so much for putting those up. And again, Dr. Faye, thank you so much for joining us for today to talk about ARFID. I really appreciate it.
Thank you so much for having me. This was really cool and interesting, and I'm excited to just contribute to putting any information out there that I can.
Absolutely. Well, again, thank you so much and have a great day.
Thanks, you too.
All right, you made it through this episode. Thank you so much for making it through. So if you have further questions about ARFID or want to know more about ARFID, go over to fearcastpodcast.com, send me a message, and I will get Dr. Faye back on the podcast to answer your questions as they relate to ARFID. Also, be sure to check out her YouTube series. It's fantastic. She's very informative, as you have heard, very clear and engaging as a communicator. So I think that would be a fantastic resource if you want to know more about ARFID. So everybody, thank you so much again. Please remember that the Fearcast is not a substitute for psychotherapy. If you need a little bit of help in your recovery, go over to fearcastpodcast.com, and there's going to be a Find Help link. Click on that, and there'll be some links there that might point you in the right direction. So until next time, everybody, take a risk, challenge yourself, and don't take your brain too seriously.